up, about 9 years ago, I actually used to live in New York, and I actually used to teach human sexuality. And when I transitioned to CDC, although my heart was very grounded in sexual health issues, 9 years ago, CDC wasn't quite ready to have the discourse that I think we're ready to have now about sexual health, particularly among young people. So I am going to talk very briefly about this study that was conducted. But because it was not my study, I feel like it would be unfair to the authors to answer any questions about it. So I'm going to direct you back to the authors who actually did the study. But what I would like to do is talk with you a little bit about what CDC has been doing with regard to adolescent health and some of the key issues that many researchers and program people at CDC and also our partners outside of CDC are beginning to deal with. So the impetus for this presentation today was the release of the data analysis that found a 25% prevalence rate of STIs among adolescent girls. The authors, however, also found that there was a considerable rate of STIs among African American, white, and Mexican American girls. And that the prevalence rate, if you look at the abstract, isn't just 1 in 4 amongst all girls, but it's actually 40% amongst girls who are sexually active. When you look at the prevalence rates of STIs in this particular analysis, with girls who have just one partner, it's still 15%. And when the number of partners increases, the percentage of STIs found among girls actually is almost half. It's actually a little bit over half if girls have more than 3 partners. Now, although the results of the study were probably some of the most widely publicized results about STDs, with the exception of the article that came out about the rise in STDs among the senior citizen community in Florida. I mean, around 2006, there was an article that came out about that, and there was a flurry, but not in the same way. It was more of a surprise, because they were like, oh my gosh, old folk are actually still getting busy, you know. And what's ironic is actually I do some work in that as well. But one particular article that came out that I like to highlight is the op-ed article that was done by Robert Fullilove, Ada Adamora, and Peter Leone. And then that particular opinion piece, that particular piece spoke most directly to what it is that STD professionals already knew. That number one, that the finding wasn't new. The 1 in 4 finding wasn't new at all. But number two, that the level of discourse around this topic, particularly among young girls, would be new, within CDC as well as outside and with CDC. One of the resources that the authors had mentioned in their op-ed piece was a publication that came out in 1997 called The Hidden Epidemic. And then that publication, and it's a book, it's not just an article, but it's a whole book, that actually reviewed and summarized the current STIs at that time. Even then, it was an estimate that the number of STIs that occur among adolescents was 1 in 4. And that was 11 years ago. What that book also highlighted was that the annual cost of STDs was really 43 times the amount of money that's invested in STD prevention. And at that time, it wasn't necessarily focused on adolescents. At that time, it was really more focused looking at ethnic groups and MSMs. And now we're beginning to do significantly more work with adolescents. Finally, one of the things that that particular report highlighted was what was needed in order to achieve STD prevention. Now, I know that you can read this for yourself, but I do want to read something very specific, and this is taken directly from the book. It says, STDs can only be prevented by intervening at multiple points. That includes behavioral, biomedical, and structural interventions on both an individual and a community level. However, these and other effective interventions are not fully implemented and utilized. And to be honest, Over time, more of those interventions have been utilized, but we still haven't fully utilized all the tools that we have available. So, what are the key questions? Well, one question is, what has changed since 1997 between then and 2008? One is the internet and the accessibility of information. In 1997, when that book was released, how many people had heard about it? Raise your hand. Yeah, exactly. I mean, there wasn't a lot of publication about that particular book or the report. I mean, and that was a significant publication for STDs. It was actually one of our, if you will, Bibles for STDs. But also in 2008, what we have realized that we really have to go beyond pregnancy prevention with adolescents. That for so long, much of our work was really geared towards just preventing unintended pregnancy. But now we have to prevent HIV, STDs, and to be honest, this wasn't something that occurred in the last 10 years. It's something that has been around, specifically with HIV, almost 3 decades now, if not more than 3 decades, and with STDs for several centuries. But yet it's now where we're actually starting to look at, if you will, triaging those 3 things so that we can provide better health care for our adolescents. So what exactly is STDs, CDC is doing about STDs among young people? I'm going to talk about 3 different levels for CDC. One is CDC, the agency. Second is the center in which my division, which is a division of STDs, is housed in. On an agency level, Julie Gerberdine, the director of CDC, started the Futures Initiative once she was appointed as the director. As part of the Futures Initiatives, we have 21 goals that pretty much guide a significant part of our work. One of the most active goal areas is amongst adolescents. It's the Adolescents Goals Team group. And it's led by Catherine Ethier, actually is one of my colleagues, who has done a significant amount of work at CDC and prior to coming to CDC with regard to adolescents. With the Adolescent Goals Team, they are probably one of the most well put together group of women. I mean, I don't think they have that much diversity. But what they do have are dedicated researchers who've been doing work with adolescents for a significant period of time prior to coming to CDC and have continued that work since being at CDC. So on a CDC level, we have that group that actually commands several $1 million that actually really tries to focus most of their work and most of their energies on sexual health issues for adolescents. With regards to our center, which is the National Center for Hepatitis, HIV, STD, and TB Prevention, and Kevin Fenton is the director of our center, we have 3 key priorities which our division has aligned with, one of which is reducing health disparities. And if I can go back to the goals teams for a moment, our adolescent goals team is technically housed in our center. That's a good thing, and that's also a challenging thing, because what's great about it is that we have that level of expertise within the centers that are really motivated, really dedicated to adolescent sexual health issues. The challenge of that is that it marginalizes the topic, because people begin to think that adolescent sexual health issues is just about prevention of STIs, HIV, and TB. And it isn't. It's much broader than that. Within our division, we have 4 different priorities. I'm only going to highlight 2 of them, because those 2 are almost exclusively focused on adolescents. One is around HPV, and we have so much work that's going on with regard to HPV. And I hate to simply direct you to our website, but if you actually do go to our website and pull up the STD website, you'll see the enormous amount of information and work that's being invested in HPV vaccine and vaccine research. But also with chlamydia. Chlamydia is the most common STI, preventable STI, amongst women in general, but particularly among adolescent women. So we have very strong recommendations that are made with regards to preventing and screening chlamydia that we're now trying to engage more professionals and more providers in implementing. And then also within our division, we have specifically a health disparities effort. We had a consultation in 2007, and although that consultation was focused on African Americans and gonorrhea, because the disparity rate of gonorrhea among African Americans is 18-1 as compared to whites, that health disparity was not unique to adult women or men, but a significant portion of our morbidity for gonorrhea as well as for chlamydia is among young adolescent women. So what are the issues? Well, I categorize them into individual, partner issues, partner risks, social, sexual networks, as well as sexual health. Now, within the field of STDs, as well as within the field of HIV, a lot of our work has been very focused on individual risk behavior, trying to get the individual to utilize more condoms and to implement individual level interventions. But this is the challenge. There was a paper that came out in January 2007 that actually found that when they compare high-risk and low-risk African American and white adolescents, that when you look at high-risk behaviors among white and African American adolescents, that there is a direct connection between risk of HIV and STDs. However, what the researchers found is when you're comparing low-risk youth, the African American youth still had an 8-fold increase of STIs and HIV as compared to white youth, even when they're engaging in low-risk behaviors. Even when they're engaging in low-risk behaviors. So even when we tell young people, make sure that you have one partner, use condoms, because of the epiprevalence in many of the communities that our young people live in, they're still at significant risk, even when they're engaged in low-risk behaviors. And an analysis that my colleagues Jamie Licklider and Sevgi Aral had conducted, they compared oral sex and anal sex, and this is actually from the same data set that the analysis, the 1 in 4 analysis was done on. They compared oral sex and anal sex among men and women who were African American, Hispanic, and white. And what they found was that the population that engaged in these behaviors most often were white. They weren't Hispanic and they weren't black. So why is it that you have behaviors and even risk behaviors that white people and adolescents engage in more often, yet the STI prevalence is still significantly lower? So it leads us to believe that it's not just individual behavior, that there's more to it than just individual behavior. So then we begin to look at partner risk. When we're looking at partner risk, there's 2 things I have up here. One is about availability and the other one is about concurrency. What we're finding about concurrency, and I'm not just talking about multiple partners at one time, but overlap between partners over time, that things like mobility actually impacts concurrency. In one study that I conducted, we found that one of the biggest predictors of concurrency was moving to a new neighborhood. That if you move to a new neighborhood, you're likely to still have a partner in your old neighborhood as well as a partner in your new neighborhood. And it could be multiple partners at one time, but it also just could be an overlap over time between partners. The other thing that actually links to concurrency is incarceration. And the cycle of incarceration of particularly males leaving communities, going into an incarceration situation, and then coming back into the community. So there's concurrency among the partners who actually leave the community and come back, as well as their partners who are left in the community, as well as the men who are in the community who are essentially prized, if you will, because there may not be, as far as perceptions is concerned, a lot of male partners in that community. So then that leads me to availability. And in that case, we're talking about sex ratios as well as what people perceive to be the sex ratio. You can actually look at a sex ratio within any given area just using basic census data and look at the ratio between men and women. However, there isn't that much research that actually links the accuracy of that the actual sex ratio with individual behavior. And a study that I did about 10, 15 years ago, I looked at actual sex ratio as well as perceived sex ratio. And what we found was that there was no significant difference between what people perceived to be the sex ratio and what the actual sex ratio was. And what that means is that you could actually use that sex ratio and use it in an analysis to try to predict and better understand sexual behavior. And what we found in that study was that when you look at perceived sex ratio, that those persons who had a perceived sex ratio, a low perceived sex ratio of number of sex partners in their immediate environment, they unfortunately also reported higher risk behaviors, a higher rate of STI history, and more unintended pregnancies. Now, I did the study with African American, Latino, Asian, and white women. It was African American women that had the lowest perceptions of sex ratios. And this study was done in Houston, and we're hoping to replicate it in New York. This was an analysis that was done by Ada Adamora, who was one of the authors of the op-ed piece. And what she found when she was looking at concurrency odds is that there was a higher rate of concurrency amongst partners who were incarcerated, specifically women who had male partners who were incarcerated, as well as people who were single, people who had sex prior to 14, specifically in the strata she looked at was between 12 and 14, and also a higher concurrency among men. Now I want to talk a little bit about sexual networks. Now this looks like a lot of snots. And actually that, let me see if I can get the, yeah, right here. What we call in social network analysis that there are called dots, barbells, linkages, and snots. Number 63 right here, that's called a barbell. And what that picture will show you is that when they did this analysis looking at a group of sexually active adolescents in a high school, that you had couples who were barbells, meaning when you looked at their sexual behavior, it was just one of two people. And then you had, can you guys see the little arrow? Yeah, okay. And then you had these other different types of shapes where you would have one person who had multiple sex partners, but with the exception of that one person, there was no other linkages elsewhere. And then you had these other chains, like these chains, where that actually looks more like a concurrency issue where you have people who are having sex with one partner who also has sex with other partners. And then you have what we call snots. And with these snots, and that's the diagram that you see up here in the upper hand corner, that is a network of sexually active adolescents. I believe the biggest challenge we have is that when people engage in sexual relationships, they think they're a part of a barbell. Okay, they think it's just me and the other person who I'm having sex with. But the problem is that particularly in communities where we have significant amount of prevalence, and also amongst young people, that they're much more likely to be a part of a snot, so to speak, than a barbell. But the belief is that they're a part of a barbell. The belief is that it's just them and the person they're having sex with, and that there isn't a concept of modifying the prevention strategies that they're utilizing in order to reduce their risk that's not grounded in that snot kind of philosophy or that snot profile. So it's not the sexual behavior that's the challenge, but it's the context in which it occurs. And within that context, we can't help but talk about core groups. Now, when we talk about core groups, we're talking about groups of infection. From an epidemiological perspective, we're talking about groups of infection, where you have core groups who may or may not engage in high-risk behavior, but do have a certain level of STI prevalence. Another type of analysis that we're looking at is called disordered mixing, where there's mixing between high-risk populations and low-risk populations. and how if within a particular community or a particular group, the larger the core group, the more likely that you can actually come in contact with STIs even if you only have sex with one partner. Again, it speaks to, it's not just individual behavior, but it is the context, and it's actually the epi-profile of the community or the group. So what are the factors that contribute to STI, and what are the things that we're actually examining? We're examining everything that I spoke of, but also we're examining more often now than ever before those social determinants. Now, there are some social determinants that CDC can't do a lot about, but at least we can try to understand how they impact risk behavior and how we can modify the interventions that are being developed in order to address some of the social determinant issues. So what are the solutions? And this is where I can actually say hallelujah. Because now we're really starting to talk about sexual health. I mean, it's been something that myself and other colleagues have been crying about for years, where it's not just about screening, it's not just about giving condoms out to people, but it really is looking at a more holistic perspective of sexual health. Now, this definition was taken from the WHO, and I just want to read it because I just love it that much. That sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. But this is the other part that I like the most. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasure and safe sexual experiences, free of coercion, free of discrimination, and free of violence. Don't you just hear the music in the background? But see, this is the challenge. This is the key challenge. I really think we are not comfortable as a society with our young people being sexual beings. We're not comfortable with the concept of having pleasure. God forbid that sex is actually pleasurable. God forbid that you want it to be pleasurable. And that is what I think we have, that's one of our biggest challenges, is just accepting that sex is a right. It is a right for us to be able to experience this with another person. And if we really want to go there, with more than one person. As long as you understand what it is that you have to do in order to minimize the risk of infection, to minimize the risk of pregnancy, to minimize the risk of being emotionally hurt by that experience, but also to maximize the joy of actually having sex. The other part of the solution is looking at men's health. Now, I didn't talk very much about men's health, but many of the issues are very specific to men's health. I'm seeing more research get funded that really is specifically geared towards enhancing sexual health among men, not just men who are incarcerated, because we actually do have quite a bit of work geared towards incarceration. I actually work with a lot of my colleagues who are working in incarceration, or with incarceration topics, but really looking at, and also not just at MSM sexuality, but looking at male sexuality, looking at the sexual health of young men, and actually trying to find spaces where they can go and have proper sexual health services other than an STD clinic. Because right now, that's pretty much all they have. I mean, Planned Parenthood does a really great job of actually saying, come on guys, dudes, come on in, you know. But there are many men who still may not feel comfortable, you know, coming to Planned Parenthood. And I have a fellow who is great, and for years he was a health educator at Planned Parenthood. I mean, but how many males do we know who feel comfortable working in Planned Parenthood talking about sexual health education and sexual health issues? And most importantly, we must continue this discourse and action regarding sex and all of the isms. I'm talking about racism, sexism, classism, that are all related to all of these social determinants that actually impact STI risk. So where do we go from here? Well, I'm going to go back to the hidden epidemic, but I've renamed the book now, and I called it The Uncovered Epidemic. So if we were to write it again, we would have to talk about it. I mean, we could literally repackage the book, talk about it in that context, and just call it the uncovered epidemic. And the way I would change it was that these and other effective interventions will need to be fully implemented and utilized in order for us to have a real impact on STDs. I'm sorry, STIs, because our division is still the division of STDs, but really the proper term is STIs. And finally, that it's going to take a collaborative and multifaceted approach to STI prevention in order for us to be completely and fully effective. Okay, see, this is where PowerPoint 2007, when you convert it to 2003, goes awry. Because there was actually a picture there. But I guess we're just going to have to do without. So my bottom line is I really wanted to just stress how it really takes partnerships like the ones that you guys have formed here today, and also further engagement with agencies like CDC. We can't do it all. And to be fair, we're not supposed to do it all. But we can all do our fair share in order to make sure that we can create the best environment so that we can all be able to enjoy, to have sex with the persons who we choose to have sex with, and I underscore choose to have sex with, also to experience that with the utmost pleasure, but also to do it in the context where we have the best outcomes, which, if you could turn that off for a moment, is an orgasm versus an STI. And with that, I thank you.